Hello everyone, today we'll be discussing chronic conditions of Alzheimer's with our secondary entity being malnutrition. So just to give you a brief overview, today we will be starting off with an introduction video to Alzheimer's. We will go into the characteristics, the symptoms, and the epidemiology of Alzheimer's, and we would end off with the complexity of Alzheimer's disease and the nutritional intervention as a rehabilitation strategy. So just to start off, we have a short video about Alzheimer's disease.
Alzheimer's. It's the most common form of dementia, and it is a progressive brain disorder that impacts one's memory, various behavior patterns, and the way they think. Alzheimer's can become severe enough to get in the way of daily tasks like eating and eventually take over an individual's life. The disease accounts for 60 to 80% of dementia cases. And although the majority of people suffering from the disease are 65 and older, approximately 200,000 Americans under 65 are affected by Alzheimer's. There is currently no cure for Alzheimer's, but quality of life can be increased with preventative rehabilitation strategies.
So we're going to start off by talking about the characteristics of Alzheimer's. We're going to start off with personality behaviors. So people with Alzheimer's tend to act out of character, so their persona completely changes, such as from a quiet demeanor to a more aggressive manner. There's also the loss of memory. In order to understand this, we first need to understand the different types of memory. So there is episodic memory, which is a memory people have of events in their lives. There is semantic memory, which is unlike the previous memory, and is not personal, but rather common to those who speak the same language. And then there's procedural memory, which is the memory that helps us carry out tasks and actions, such as how to use a fork and knife. Going on, there's also physical changes, which is an indirect cause from Alzheimer's, such as you may forget how to chew or how to swallow, which can cause weight loss as a result. So normal intake of food is not being maintained. And you also have vulnerability to other diseases and infections as well. Then going on to behavior, this is a common thing seen in Alzheimer's patients is wandering during the day and night. This can be due to communication problems, but it's hard to find out why, which goes into communication. And communication, people with Alzheimer's usually have a hard time with production and comprehension of language. So many patients tend to lose the ability to read and interpret signs. So now we will be talking about symptoms. So going into challenges in planning or solving problems, people with Alzheimer's tend to face changes in their ability to develop and follow a plan or work with numbers. This can interfere with simple day-to-day activities at home, school, or work, and their concentration levels may be affected as well. There's also confusion with time or places. So people can lose track of dates, seasons, passage of time. They might not understand what's happening immediately and forget where they put things. So misplacing things, losing ability to retrace steps. Things may end up in unusual places. There's also poor judgment. People with Alzheimer's may also experience changes in judgment or decision making. As a result, pay less attention to grooming or keeping themselves clean. Alzheimer's disease can also lead to cognitive impairments, both acute and chronic in nature. Examples include gastrointestinal diseases and swallowing disorders, which cause malnutrition as a result. In summary, Alzheimer's disease can also lead to depression in individuals, leading to individuals to lose interest in food, so they're eating less. Poverty, which limits the range of options. Impaired taste, vision, smell, poor hearing, so reduction in senses. Lack of access to shops, so again, limitation in food sources they have access to. There's also poor mouth and tooth care as a result, poorly fitted dentures or no dentures, which discourages eating. Isolation and living alone, a lifestyle factor that can prevent them from having a better quality of life. There's also bereavement, which is loss of loved ones, that contributes to depression, and also loss of manual dexterity, which is a physical disability where they can't grasp stuff, so they have problems with self-feeding.
Now we're going to discuss the epidemiology of Alzheimer's disease. The prevalence globally of Alzheimer's disease is 3.9% of dementia globally in people aged 60 and over, and 6.4% in North America, affecting more than 25 million people currently. The incidence rate is 5 million new cases of Alzheimer's disease yearly, so the incidence rate can be termed as 15 per 1,000 person years. The impact on current healthcare systems and healthcare utilization is our next topic. So there are physical disabilities and institutionalization, which can result in a greater need for long-term care homes or nursing homes and hospital beds. There is also an enormous cost on resources which are needed for adequate care of dementia or Alzheimer patients, which is estimated to be $150 billion US. Now we will go into the descriptive epidemiological factors. There are a variety of lifestyle and environmental factors that can increase or decrease one's risk for developing Alzheimer's disease. These risk factors and protective factors are described by the vascular pathway hypothesis and the psychosocial hypothesis. The vascular pathway hypothesis states that factors such as tobacco use, alcohol consumption, obesity, hypersensitivity, high serum cholesterol levels, nutritional and dietary factors, diabetes, and cardiovascular disease increase one's risk for developing Alzheimer's disease. Whereas the psychosocial hypothesis states that factors such as higher education and socioeconomic status, social engagement and networking, physical activity, positive mental activity decrease one's risk for developing Alzheimer's disease. Other etiological factors that can increase one's risk include inflammation, toxic exposure, and other factors including brain injuries, such as concussions that have happened earlier on in life. We will now be discussing comorbidity as it relates to the complexity of Alzheimer's disease. Generally, the complexity and triggering mechanisms include mitochondrial dysfunction leading to oxidative stress, aging leading to epigenetic modifications in gene expression, increasing one's susceptibility to diseases and altering the response to stress, neurodegeneration resulting from the disruption of mechanisms which regulate methyl group availability, and changes of global histone acetylation levels. Now, how is Alzheimer's disease considered chronic? Alzheimer's disease is considered a chronic disease because it persists for a long period of time. Once you're diagnosed, you have it until the end of life and can only take measures to manage it. It lasts for more than 3 months and generally cannot be prevented by medications or vaccines and has no cure. Alzheimer's also has the potential to lead to malnutrition. Alzheimer's disease is strongly correlated to malnutrition since, as the primary disease progresses, people tend to forget or refuse to eat and consequently have poor diet, inadequate in energy and protein, which can lead to further problems such as weight loss, with unintentional weight loss being a key predictor of mortality in the elderly. Alzheimer's disease patients who are institutionalized generally display more advanced stages of the disease compared to those who live at home, with their food intakes dependent on the institutional food services as followed by their healthcare professionals to ensure adequacy of nutrition. Usually, when appropriate feeding assistance is provided, malnutrition might not develop. We will now transition into addressing malnutrition as a secondary entity to Alzheimer's disease, using nutritional intervention as a rehabilitation strategy.
As you can see in the diagram, it depicts a very basic nutritional rehabilitation program. As you can see, it starts from a screening, so you need to find patients who are most at risk. These are probably going to be elderly patients who are in an aged care home or have long stays in the hospital because nutritional status goes down with the longer hospital stay. Patients who have neurological diseases are also at risk for malnutrition. After this, you need to identify the deficiency. So this is a diagnosis. Then you need to implement an intervention, and this needs to be monitored and evaluated over the patient's life. As you can tell that this is a cycle, so it needs to be reevaluated and reassessed based on need.
Continuing, there are many factors that can contribute to the development of malnutrition in Alzheimer's patients. Rehabilitation programs related to this field focus on the management of these factors in order to improve quality of end-of-life care. The functional decline associated with Alzheimer's can average 20 years, which is why nutritional rehabilitation programs are so important in the reduction of healthcare utilization in the long term. Dietary intervention is a rehabilitation program used to prevent, monitor, and improve nutrition in patients with Alzheimer's disease, and this begins with the assessment of the patient's current diet. The food guide pyramid can be used in a routine screening process to assess the presence or absence of major food groups in the patient's diet. In addition, the patient can be assessed for nutritional deficiencies that need to be addressed, such as vitamin D and calcium. These two can both contribute to the onset of osteoporosis. This further contributes to the complexity of this disease when combined with the unsteady gait and frequent falls that can result from the progression of Alzheimer's. After an initial assessment has been conducted, important markers that can be evaluated throughout the intervention include weight, caloric requirements, and hydration. These components can be monitored by the healthcare provider upon regular visits in order to assess if the patient is in line with their dietary goals. Another important component of effective dietary intervention is self-feeding. This should be maintained for as long as possible for preserving independence and quality of life. However, this is not always possible as swallowing difficulties and aspirations are risks of Alzheimer's progression. In the case where patients can no longer feed themselves, it is suggested that natural feeding is continued by caregivers or trained professionals in order to maintain that level of patient dignity that contributes to their quality of life. Moving on, we will discuss a research publication we found on the nutrition intervention study, which was a nutritional intervention targeted towards older adults with early-stage Alzheimer's disease. We will discuss this method used in the study and assess the validity of their findings using the Pedro scale. The NIS was conducted to prevent weight loss and malnutrition in community-dwelling older adults. Patients were recruited from memory and geriatric outpatient clinics along with their caregivers who played a large role in the study in terms of diet reporting. An initial diet assessment was conducted by a questionnaire and dietary recalls that could be assisted by the caregiver. Participants were then allocated to the intervention group and the control group, where members of the intervention group received targeted dietary recommendations, and participants in the control group received only Canada's Food Guides leaflets.
Now we will be talking about the rehabilitation techniques within the study. So before the start of the intervention, review of medical charts was necessary, as well as completing a questionnaire and implementation of other screening instruments. Individual recommendations were made for specifically each patient and their caregivers, taking into account primary dietary deficiencies. It's important to provide lists of good food sources of different nutrients that they were deficient in, as well as other additional resources in plain language. Diet teaching was also important, which consists of providing consumer-oriented educational materials that give tips on good food sources of those targeted nutrients, and advice on adjusting favorite dishes to increase energy and protein intake. Frequent follow-up and accessibility to nutritional resources throughout the duration of the study were also important. Use of validated tools and caregiver assistance are key for implementation of this rehabilitation strategy in order to monitor the patient's diet. Continuing, active participation of caregivers was needed for the delivery of the dietary intervention. This was to ensure access to and consumption of a healthy diet, which could allow the individual to remain at home for as long as possible. Multiple approaches used for dietary recall include independent recall, assisted interviews, and caregiver recall, which help to accommodate the cognitive limitations of the patients. Dietary recommendations and close monitoring of participants occurred over a 6-month period, which led to small increases in intakes and more varied food consumption, greater lipid intakes, improvements in adequacy of protein intakes, higher energy, and increased consumption of good dietary sources of calcium, which is important since these Alzheimer patients are usually elderly people who have different dietary requirements. Through the experiment, dietitians recommended members of the intervention group to monitor their weight regularly, have smaller, more frequent meals, or increase their overall energy intake. For some, they were specifically told to increase the amount of protein or fat they consumed. The nutrient-based recommendations were to improve specifically in calcium, vitamin D, and vitamin K. In general, the participants needed to eat more nutrient-dense foods, improve their social interactions, such as going out to dinner with friends, and become more active. All participants in intervention and control groups met macronutrient intake recommendations for DRIs, also known as dietary reference intakes. The intervention group improved as a whole at follow-up, mainly because of the increased energy intake. BMI was stable over the study period for both intervention and control groups. We will now be looking at the application of the Pedro scale, as seen on the slide. To assess the quality of this research publication, we will be using the Pedro scale. as a refresher, I have provided you with the 11 criterion as shown on the slide. These criterion are used to evaluate the internal validity of randomized controlled trials, such as the one we have presented. We will be starting off by talking about the criterion met. Criterion 1. The eligibility criteria of the study was clearly identified by an inclusion criteria of 70 years or older, in early stage Alzheimer's or with a MMSE score of 22 out of 30 or greater, demonstrated the ability to provide informed consent themselves, did not have any significant weight loss in the previous year, which was quantitatively defined, in good physical health, had a willing caregiver, and spoke English or French. There is also an extensive list of exclusion criteria that included to an array of morbidities and a BMI of less than 18.5, which would have indicated an existing state of malnutrition prior to the study. Criterion 4. The control group and the treatment group were considered to be similar at baseline for many key prognostic indicators, as demonstrated by the table on the screen. Criterion 8. As demonstrated in the study flowchart, there was about a 9% dropout rate, meaning that some subjects who completed the T1 interview were lost to follow-up. However, this satisfied the criteria as measures were obtained for more than 85% of the subjects who were initially allocated to the control and treatment groups. Criterion 9 was met as it was specifically stated that data was analyzed using intention to treat, which refers to assessing study participants according to their group assignment, regardless of whether the participant adhered to the control or intervention group for the entirety of the study. Criterion 10 and 11. It was stated that independent and pair t-tests and non-parametric Wilcoxon-signed rank tests were used to assess between group differences in outcome variables. Also, results were presented as means with standard deviation. Therefore, both criterion 10 and 11 were met. Now we're going to be looking at the criterion that were not met. Criterion 3. It was stated that subjects that met inclusion criteria were determined by clinic personnel through the use of an eligibility checklist, and they were then referred to the study team. However, it was not stated that these personnel would be unaware of which group the subjects were allocated to. In fact, it was noted that a copy of the participant's dietary assessment was sent to the family practitioner and the clinic physician. Memory or geriatric clinic staff, such as a nurse or social worker, and public access community services were contacted to provide further referrals as needed for the participant and caregiver. Criterion 5. Study participants were not blinded, as those subjects in the intervention group were aware of being in this group. Criterion 6 and 7. There was not blinding of the dietitian who administered the intervention, which can be considered the initial interview, and the distribution of individualized dietary recommendations, as they were aware of the group the study participants were in. The dietitian was also the interviewer and again was not blinded to whether participants were in the control or intervention group, which could have allowed for bias. This was used in conjunction with self-reporting and caregiver reporting as means to obtain the dietary reports. However, since participants were also not blinded to their allocation, this criterion was not met. Criterion 2, however, was unclear. It was not stated in the article as to whether subjects were randomly allocated to their groups.
Okay, so moving on to limitations. The study design basically showed that only moderate validity was apparent and there were some criteria that were not feasible. However, it was not stated in the article that criteria such as blinding of subjects and concealed allocation was attempted. It was expressed that due to budget limitation, there was only one dietitian on the study, which did not allow for blinding of the interviewer. It was recognized that this could have led to bias. Additionally, the article stated that being enrolled in a dietary study could have influenced subject and their caregivers in either groups. This is called the Hawthorne effect. So basically the Hawthorne effect is when individuals alter their behavior when they know they are being observed. So in this case, caregivers can alter the food that is being consumed by the patients. As for cognitive limitations in patients with Alzheimer's, this scenario led to caregivers assisting in self-reporting. And lastly, although criterion 1 was met, there was extensive inclusion and exclusion criteria, which ruled out many Alzheimer's patients suffering from comorbidities. Many comorbidities contribute to malnutrition, and it makes it so that it is less generalizable to other patients. So this concludes our presentation. We hope you enjoyed, and thank you for listening.